Good afternoon. I'm Dr. Joss Reimer, Medical Lead for the Vaccine Implementation Task Force. Today, I am pleased to announce that eligibility continues to expand for the vaccine. Community-based eligibility for people who live or work in specific jobs aged 18 or older is expanding. Beginning today, people who are 18 or older who live in Point Douglas North, Downtown West in Winnipeg, as well as Brandon Downtown, are eligible. Nous élargissons les critères d'admissibilité des personnes de 18 ans et plus qui résident dans certaines collectivités du Manitoba ou qui occupent certains emplois. De même, à compter d'aujourd'hui, nous ouvrons l'admissibilité au vaccin pour les personnes de 18 ans et plus qui résident dans Point Douglas Nord et dans le secteur ouest du centre-ville à Winnipeg, ainsi que pour les personnes de 18 ans et plus qui résident dans le centre-ville du Brandon. You are also eligible if you work in those communities in a specified job. There are maps on the province's website of all eligible communities, along with a list of the specified jobs so that you can see where you fit in. Community-based eligibility helps to address systemic barriers while providing added protection when entire households can be immunized at the same time. As I mentioned last week, we are choosing these communities based on an analysis of COVID-19 case rates, population density, the percentages of racialized populations, the income, and amount of suitable housing in those areas. Adding super sites and clinics is another way to reduce barriers. We want to bring the vaccine closer to people. We are also putting the vaccine in places that people know and trust, like the urban Indigenous clinics that launched this week, or the immunization clinic that was held at the Manitoba Inuit Association on Monday. And today we have launched another really important resource to address another barrier, language access. Now, anyone who calls 1-844-626-8222 to book an appointment can speak with someone in their preferred language. The person on the other end of the line will be able to link in an interpreter who can provide real-time support to help make the vaccine appointment. This service is available in hundreds of languages. Ahora, cualquier persona que llame a 1-844-626-8222 para reservar una cita puede solicitar hablar con alguien en su idioma preferido. El agente del centro de llamadas podrá conectarse con un traductor que puede apoyar en tiempo real para ayudar a programar la cita de vacunación. Este servicio está disponible en cientos de idiomas. When you book your vaccine at a super site, you can also now request spoken language interpreter services for that appointment. This service will be provided over the phone. Lorsque vous appelez pour prendre rendez-vous dans une super clinique, vous pouvez maintenant demander les services d'un interprète linguistique pour votre visite sur place. Ces services d'interprétation seront offerts par téléphone. Y una tercera vez en español, cuando llame para reservar su vacuna en un supersitio, ahora también puede solicitar servicios de traducción para esa cita que será disponible por teléfono. Individuals also can ask for American Sign Language interpreter services when they make an appointment at a super site. This will be provided by tablet or on a computer. This is so important to our immunization campaign, and I want to thank the many organizations, community leaders, family members, and volunteers who are making sure that information about vaccines is shared with people in their communities in their preferred languages. The province is doing some of that work, and the development of these language services is good progress, but I know that there is still room for us to improve. This vaccine campaign is the largest in our history, but sometimes our greatest successes come from our personal connections. We are all influenced by the people around us, by our family members, our friends, our social networks, the people in our community, and the people that we look up to. It's National Immunization Awareness Week, and so it's the perfect time to talk about the COVID-19 vaccine, what it means to us, and why we choose to be immunized. Earlier this week, the Blue Bombers and Valor FC stepped forward as Protect MB ambassadors so that we can tackle COVID together. They join many other Protect MB ambassadors who are sharing their stories about why they've gotten the vaccine or why they'll choose to be immunized when it's their turn. I would encourage you to read their stories and then share your own story. For me, the vaccine means hopefully being able to see my parents again soon, spending time with them like we did before COVID. It also means knowing that my patients are protected and that while they already have health concerns that they're coming to see me for, that I'm not increasing their risks by potentially spreading a virus to them. As a public health doctor, I love hearing and reading people's immunization stories. So I do want as many of you as possible to add your voice to National Immunization Awareness Week by tagging #ProtectMB or adding a frame to your Facebook profile. So thank you to Manitoba for being part of this life-saving and life-changing vaccine campaign. And with that, I will hand over to Johanu.
Good afternoon, everyone, and thank you very much, Dr. Reimer. I'm Johanu Botha, Operations Planning and Logistics Lead for the Vaccine Implementation Task Force. Before I get started, I also want to share what the vaccine means to me. Of all the many operational challenges we have tackled during the COVID fight, it is the vaccine rollout that comes with so much hope. Each super site and pop-up clinic that we launch and each focused immunization team that we deploy is one step closer to building a light at the end of the tunnel. Building this light is an immense privilege for everyone on the task force. On a more personal note, similar to Dr. Reimer, both my parents have now received at least one dose of the vaccine, which, although I played only a small part in getting that vaccine to them, is the best gift I could have given them during a year when our family, like so many families in our province, could not spend nearly as much time together as we would have liked. We continue to implement our plans so that we can immunize as many Manitobans as possible, as quickly but as safely as possible. As of today, almost 450,000 doses have been given to Manitobans. This means more than 34.7% of us have been immunized. Today alone, we expect over 9,000 doses to be administered, and we will completely exhaust our vaccine supply we have on hand within a week and a half if we don't get another shipment from the federal government. I have spoken before about our commitment to get vaccine into arms quickly, so I thought today was a good day to revisit some of those milestones. Our vaccine campaign started on December 16th. It took us 87 days to deliver our first 100,000 doses. Slowly, vaccine supplies ramped up, and so did our work. It took only 21 days to deliver the next 100,000 doses to get us to 200,000 total. To reach our next milestone, a total of 300,000 doses, it took us 12 days. And most recently, to deliver another 100,000 doses where we made it to 400,000 doses in the arms of Manitobans, 9 days. There's more vaccine on the way, and we are putting our plans in place to get that vaccine to people throughout the province. Appointments are now available at the Lila Avenue Super Site, which opens next week, May 7th. I am also really proud to announce, on behalf of the team who's been working so hard to put these plans in place, that the Steinbach Super Site on Lumber Avenue will open on May 18th. In addition, today we are announcing that the second super site for public Prairie Mountain Health will be located in Dauphin and expects to open on May 10th. We will have more information about these sites in the coming days, including when people can begin to book their appointments at these sites. Thank you very much, and we can turn it over to questions.
Thank you. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this afternoon from Global News, Onya.
Yeah, hi there. It's been 7 days since the age eligibility dropped to 50. So as we open up all of these hotspots, how much longer is it going to take to drop the overall age eligibility going forward, even for AstraZeneca? I know we asked that during the technical briefing, but if you could give that answer again, that'd be great.
Yeah, so for the overall age eligibility, I don't have any dates at this point. We do have more priority communities that we want to announce. So it's really critical that we do get eligibility opened to the communities where we know that high risk of increased transmission and increased severe outcomes is still prioritized. So that work is going to continue this week. And then after that, we'll look again at where we are and determine what would be the best approach for going forward with Manitobans. What I will say is that once we do open back to the general population, we expect that the age groups will drop quite rapidly because so many people have already been made eligible through other mechanisms, including the priority communities. So you will see that while we haven't been expanding the ages in the last week, the overall impact to people's access will not be as large as people might be feeling when they see that the age hasn't changed. With regards to AstraZeneca, the National Advisory Committee on Immunization did release a statement that provinces could go down to age 30 in certain circumstances. And the biggest factor we needed to consider was what was the rate of infection in our community at the time. The higher the rate of infection, the more beneficial the vaccine becomes, even for younger ages, compared to the very small risk of the blood clots with low platelets. So we are hoping that we'll be getting some doses of Johnson & Johnson in the near future. And we plan this week to come up with what our eligibility plan will be for those doses should they come. We don't have any finalized date from the federal government, nor a number of doses confirmed, but we want the eligibility to be ready for whenever those do come. So I expect that later this week or early next week, we'll be able to finalize whether or not we change the age for AstraZeneca and Johnson & Johnson, whether we start to look again at some of those health conditions or take a different approach.
Thank you for that. And there's a document for physicians online that's causing some confusion. Many people think that high-risk pregnant women and cancer patients under 40 can now get a referral for a vaccine. Is there anything at all that high-risk pregnant women or cancer patients under 40 can do to get priority for a vaccine?
So we do have a clinical practice guidance document on our website for clinicians to help guide them on their discussions with patients about the risks and benefits of the vaccines compared to the virus for different health conditions. The document doesn't set up eligibility based on those health conditions. The purpose really is to provide that clinical guidance to assist clinicians when they have those conversations with people. For individuals who are going to be starting immunocompromising treatments, we do have a process set up with Cancer Care Manitoba, as well as with some of the specialists that work with these populations, including rheumatologists and immunologists, to ensure that we time their vaccine appropriately to facilitate their treatment when they need it, because they may not be able to respond to a vaccine after they start that treatment. But the process is more around timing and doesn't actually change eligibility for those individuals. So the purpose of the guidance document really just is guidance for clinicians.
From the Brandon Sun, Kim.
Good afternoon. Dr. Reimer, I'm just wondering, Could you just walk us through the mechanics of how the access to 100 different languages will work? Say, for example, if somebody calls and their mother tongue is Spanish. Can you just walk me through that?
Sure. So when somebody calls, this is similar to the service that we use in our clinics when we can't have an in-person interpreter. If the person indicates they need an interpreter, the call center agent is able to call the interpreter services line and request the language that the individual is asking for. So the interpreter services will then locate an interpreter over the phone who can join the conversation, and they get linked in as a three-way phone call. So then what happens is the individual can do all of their speaking in, as you mentioned, the example of Spanish. The interpreter will then take that information, translate it into English for the call center agent, and likewise everything that the call center agent says gets repeated again in Spanish for the individual so that they can hear it in their own language. So as soon as somebody calls, when they speak to that agent, they can request the service, and then that third person, the interpreter, joins the conversation.
Thank you so much. My next question is, do we know how many doses of AstraZeneca are in the medical clinics and the pharmacies that are left in Manitoba?
We do. It's on the public dashboard. We know that we have had 59, so just under 60,000 doses of AstraZeneca Covishield administered. The dashboard would have updated right now online, so I don't want to give an inaccurate figure. I'm guessing it's probably around 20,000 that's left. At the rate that our pharmacists and clinic partners have been moving through that amount since we dropped the eligibility to 40 plus, we expect to probably move through that fairly quickly.
From CJOB, Skylar.
Thank you for your time, you two. Just want to build off Anya's question from earlier. We have, heard from lots of families and individuals who either live or are immunocompromised, but they're in that younger age category, in 20 to 40, where they don't qualify for any shots. You said a few days ago that the new prioritization program has done a good job taking care of those who are most at high risk, and you're starting to move into medium risk. So I'm just wondering when the timeline is for folks like that to be able to look forward to getting their shot.
Yeah, so that's something that our medical advisory table is looking at right now. We met with them yesterday to look through different health conditions to assess what the increased risks really are. Largely speaking, for those who are immunocompromised, the increased risk associated with COVID is not that much higher than the general population, and certainly not as high as it is for folks with things like chronic kidney disease. So it's a challenging assessment because there are so many different health conditions and so much variation even within a health condition. But that is a task that we've asked the medical advisory table to look at and to provide us with some advice back on how best to reach these individuals as we move forward.
Thank you for that. And I guess my second question could be for either of you. It's been a pretty tough week. I think a lot of Manitobans were really looking forward to summertime as, some sort of finish line, or at least a chance where life as we know it could get back to normal and we could enjoy a mostly normal summer. And of course, today is the first day of new restrictions. They take us over the May long weekend. We expect, herd immunity, at least via the first dose, to be achieved in about 5-6 weeks' time. And, given the current guidelines, maybe 4 months after that, everyone that's eligible will be able to get their second shot. Is that a realistic new finish line? Is there a date that, or even a general month or time of year where Manitobans can really look forward to getting back to doing the things we love?
Maybe I'll speak to the timeline of the rollout, and then in terms of the epidemiology, then I'll pivot to Dr. Reimer. In terms of that second dose, and we're on the cusp of finalizing the full aspects of all of our second dose plans, so we hope to release that fairly soon as next week. But what I can say about the second dose is by the time that rolls around, we will be in a scenario of high vaccine supply into the province. So when we started off this campaign, and we were looking to administer the first doses to Manitobans, we were in a situation of severe scarcity, hence the duration of this campaign. By the time we're done administering first doses to all Manitobans who would like it by early June, we will have enough vaccine coming into the province at a weekly rate to be able to move through that second dose much quicker. So we're looking at how to estimate that timeline and how to get a strong idea of when that timeline might be. But the 4-month is a medical recommendation in terms of how long we can extend the second dose. It's not an operational one. We will not be waiting that long before everyone has had their second dose for those who would like it. But Dr. Reimer, maybe over to you in terms of how that will impact the epidemiology.
Yeah, I mean, certainly that's a bit of crystal ball looking, but I don't think, if I had to guess, that we're going to have to wait for a second dose to really see the benefits of herd immunity appearing in the community if we get everybody signing up for their first dose. That first dose being, protective 80% of the time, that's an awful lot of people who are protected. And the second dose, might bump that up by 5 or 10%, but isn't going to take us to 100%. So really, what's critical to reaching herd immunity and seeing those case numbers drop and then hopefully seeing those public health measures decrease is getting everybody who's eligible in as quickly as possible for their first dose. So, I've said this so many times, but it's no less important today as we're seeing increases in the case numbers in our third wave. We really want everybody to go and get that first dose as soon as they possibly can. And we want to get a first dose into every single adult in Manitoba by June, so that we can get that herd immunity going, and maybe we can have a somewhat normal summer even as we're going through dose 2 administrations.
From the Winnipeg Sun, James. From the Winnipeg Sun, James. Okay, we'll move on to CBC Radio Canada and Julian.
Good afternoon. I'm wondering, does the lack of AstraZeneca vaccine that we see right now and the inconsistency of modern doses shipments maybe force you to speed up on the super clinic strategy, or at least rely way more on it than you expected?
I think the question was around, are we relying on the super site strategy more than we expected? And I would say, no, I don't think so. The plan has always been to use Pfizer to a large extent through our super sites. So the vast majority of Pfizer coming into the province each week is being pumped out through one of the super sites in each of the regions, soon to be 2 super sites in each region. And we'll continue to do that as the Pfizer supply increases, starting next week. Pfizer is well situated to be matched to that delivery model. It's tougher to transport. They come in very large trays. So it's always been the plan to use that amount of Pfizer through our super sites. Now, that said, we want to be creative, and in case there is the kind of volatility around the Moderna and AstraZeneca supply, if that continues, we want to be able to be creative and see how else we can use Pfizer. And we've begun to do that already. Our urban Indigenous clinics are much smaller than a super site. They, to a large extent, use Pfizer. So we've got a dry run at using Pfizer in different ways. We've shipped Pfizer up north, especially recently when the age eligibility dropped to 18 plus, so they could get more vaccine in alignment with the greater population now eligible. So we can use Pfizer in many ways, but it is best situated for the super sites.
Okay. Regarding the the vaccine hesitancy. I see that you are working with religious leaders. I'm just wondering, did you see some hesitancy linked to religion?
You know, the data that we have tells us what geographies are showing reduced uptake compared to what we've seen on average in Manitoba. And so it's not that we have any clear scientific data to say that it's religion specifically leading to any sort of hesitancy. Rather, it's more who are the community leaders and how is the community organized and how do they connect with each other. And looking at the individual communities, it's key for us to identify those community leaders, which are often religious leaders, so that we can help build confidence in the vaccine through a trusted voice, through somebody that if we can connect with and help identify any barriers or concerns they may have, that they could serve as a bit of a champion for the vaccine. I think all of us, regardless of our community, we want the best for ourselves, for our families, and so we want to be able to help identify what are the information gaps or what are the concerns so that we can help those communities feel more comfortable with the vaccine and get them protected as much as all the rest of Manitoba.
Thank you.
From CBC Manitoba, Bart.
Buenas tardes, Dr. Reimer. Okay, so on that note, we look at the lowest vaccine uptake. It's in the Stanley Health District that overlaps with the Stanley Rural Municipality. There's a lot of what has been described as community living situations in that area. Is the province and is public health and the vaccine team going to specifically work for with how-to-right communities in that area to ensure vaccination rates are closer to the provincial average?
Yeah, I mean, so to be clear, we don't know that this is Hutterite communities specifically. There's many different people living in the Stanley area as well. Winkler has some of the lower uptake rates in the province. And so we do have individuals in government who have a lot of connections with these communities, and we are working to connect with leadership throughout Stanley and Winkler, as well as the other communities that were identified as having lower uptake. And so some of that comes from the individual in government who may already have those existing connections. But we also in public health have a long history of working, particularly in Southern Health Santé Sud, trying to reach these communities and address any issues they may have with vaccine confidence. So working with the regional health authority and their existing relationships and knowledge of the communities is essential as well, because they have that local knowledge to be able to identify who are the best leaders in those communities that we can reach out to and connect with.
Thanks for that. Along the lines of what the global folks were asking about, and we've seen in other provinces that some people who are younger, who have medical conditions, compromised immune systems, pregnant, they have been prioritized at a younger age. So what would you say to somebody in Manitoba who is under 40, not eligible by profession, and not eligible by geographic area, and has a serious medical condition, such as cancer, such as immunocompromisation, such as pregnancy, and can't get a vaccine right now? What would you say to those folks?
We are looking at everybody in Manitoba all the time and trying to make the best possible decisions with the limited resource that we have. These are impossible decisions. We are constantly having to choose between one group or another because we don't have enough doses. And this weighs very heavily on the team. A lot of us have friends or family members, and some members of the team themselves have these health conditions that make them feel stressed about COVID as well. So we are still working on doing that going forward and trying to pick the best possible way to reach the people that we are seeing in Manitoba are at highest risk. So we're relying on our local data. We're looking at data from other jurisdictions as well, and the expertise from our medical advisory table. we had hoped that with AstraZeneca, we would be able to do a lot of the priority health condition approach. But with the appearance of the still rare but present risk of blood clots and low platelets, that ruined those plans at least temporarily. But we're bringing that back to the table as another opportunity for discussion as NACI has given new guidance around potentially going down to age 30. So, we are looking at this right now. We're looking at dose 2 prioritization, and trying to make the best possible decisions that we can.
From the Canadian Press, Steve.
Hi there. I've got some questions on the geographic areas where you're seeing very low uptake. You mentioned some areas in the Southern Health region, and you say it's not necessarily tied to religion. And I note that in the surrounding areas, like the Stanley is an area of very low uptake, but adjoining areas like Roland or Altona are not on the low uptake list. So have you been able to determine why one area is very low uptake when an adjacent area with similar demographics is not?
Yeah, it's difficult because there's always a bit of an artificial border when you create any sort of data analysis. So the health districts don't necessarily reflect exactly how communities organize themselves, or how different cultural groups may be geographically located. And so that makes it a bit challenging to try to interpret exactly why on one side of the border of a health district we see a lower uptake than on the direct other side. What I would say is overall most of the lower uptake has been in either certain parts of Winnipeg or in Southern Health Santé Sud. So it does seem that there are some consistent concerns and or barriers to access that are appearing in those two regional health authorities. When we look at Winnipeg, we see much more issues around barriers to access just generally, where we have a lot of folks who experience a lot of barriers to healthcare, to getting information, to booking appointments, and where super sites don't serve them very well. We imagine the stress that somebody who's homeless might experience by going to a super site. While we know that our staff would welcome that person, that may not be their experience historically, and so it could be quite a scary thing for them to want to attend a super site, on top of the fact that booking and things is really challenging. What we're seeing in Southern Health Santé Sud is that it does appear to be more concerns around the vaccine and less about access, given that the lowest rates are actually quite geographically close to the Morden super site. So with Stanley actually being right around Morden and then Winkler being about a 15-minute drive, it does appear more to be concerns around the vaccine as opposed to anything around inability to access the site. So we need to connect with these communities. So we want to work with Southern Health. They have a lot of expertise and experience in their communities. The public health nurses live and work in these communities, so they know their communities and have a wealth of expertise to help us connect. And even on the vaccine task force, we have people who are connected to these communities ongoing and can provide us with a lot of advice about how best to understand the challenges and then how to address them.
And it was mentioned in the technical briefing this morning that you've seen hesitancy in these areas with things like the flu shot and even childhood vaccines. So what specifically can be done to make the uptake grow?
Yeah, so we weren't surprised at which geographies ended up with a lower uptake, because those have historically been areas where we do see less uptake for influenza and for some of the childhood vaccines as well. And so this is something that public health has been working on for a long time to improve confidence in the vaccine in those areas. It's right now it's quite a bit more urgent than it has been in the past, because we want to protect the members of our community that live in in Stanley, in Winkler, in Hanover. We don't want to see ongoing illness and hospitalization and death in those communities. So it's really urgent for us to do even more work and reach out more than we have in the past. And so we are really trying to gather more information to understand what the concerns may be, but also to connect with those trusted voices. And we know that people are influenced by the people around them. And if someone that you trust and you look up to gives you advice in one way or the other, you're often going to take that to heart, and that's going to play a large role in your decision making. So we want to get those trusted leaders on board and help so that they can inform the process on how best to connect with the communities, but also that they can connect with the communities armed with all of the best information available to improve the confidence that their communities will feel in the vaccine.
From CTV Winnipeg, Michelle.
Hi, Dr. Reimer. I'm looking at this vaccine uptake by health district, and all of these lower ones mentioned are in Winnipeg or in the Southern Health region. Do you have any data on uptake in the Northern or Prairie Mountain regions? Are those ones higher, or where are we with that?
So we have uptake information for all health districts in Manitoba, and the ones that we included in the technical briefing were those that had lower uptake than average compared to other parts of the province. Now, it's somewhat artificial, the discrepancy, because eligibility hasn't been the same across the board. So certainly some communities have more opportunity to have higher uptake because more of their community members are eligible. But at the same time, it is also reflecting historical patterns of vaccine uptake. So I think that there's many things at play. Certainly, when we look at Stanley and see that only 6% of those individuals have been immunized, we know that far more than 6% of the people living in that community are eligible for the vaccine. So certainly, the eligibility only plays a small role in the difference of the numbers, but yeah, we have looked at every health district in Manitoba, and we will continue to watch that so that we can try to understand where gaps may be and provide extra resources and information and outreach to those areas.
Thank you. I'm also looking for an update on the correctional facility rollout. How many doses are expected to go out into the provincial correctional facilities or federal ones, and which ones will you be targeting in the coming weeks?
So I don't have the exact number of doses. I don't know. I'll try answering, and I'll hand over to Johanu in case he has more of the operational background. But certainly the intent was to provide doses to all adults who are in corrections in a provincial correctional facility. The federal government has been responsible for the vaccine rollout for any federal correctional institutions. So that work is being done by them. But our intent is to offer a vaccine to every single person in a provincial corrections system if they're 18 and over. And so I know that that work either has just happened or is about to happen, but that's where we're at right now in the rollout for congregate living is with correctional facilities. So if we haven't completed it, we certainly will be in the very near future. I don't know, Johanu, if you have any other details?
No, thanks, Dr. Brown. I think that covers it very well. In terms of the numbers of doses, I don't have that on hand either, but we should be able to get that.
From City News, Jonas.
Good afternoon, folks. When we just want to break down some of this hesitancy we are seeing in the Winnipeg area, I want to just dig into the barriers that some folks are facing and the efforts now underway with language translation and stuff. I guess this would probably come from a direct analysis of the barriers that are facing and evolving the coverage to deal with this. Is that accurate to look at this?
Say that it comes from a lot of sources of information. I mean, we look at our historical experience. We've certainly connected with stakeholders, community organization, community leaders to get information to help us understand where there may be challenges. I mean, certainly something like a language barrier is a substantial challenge for someone to book, to show up at a clinic. You know, having lived in countries where I'm speaking in my second or third language, it can be very intimidating to have to go and seek healthcare when it's not your first language and struggle to understand what the person is telling you. So it's certainly no surprise that people would be hesitant when it's not their first language. So that's one of the really important barriers that we can work at improving. But we also know that people experience a lot of other barriers in life. It can be very challenging, particularly for people who are in lower income jobs or jobs that don't have the same sort of sick days available. It can be very difficult for them to take time off of work to come and get a vaccine. And so bringing it to them in a location that's more convenient can make that a much easier process for them than having to travel across the city when they may have childcare concerns or their job is a concern. So there's a lot of things that we want to continue working on. I think a lot of our focus from the operations side has been getting as many vaccines into arms as quickly as possible. And that's really critical when we're thinking about the transmission in the community overall. So even from a clinical standpoint, we strongly agreed that just getting the doses out quickly was really important as we saw that this third wave was on the horizon. And now that we're getting closer to being able to reach the majority of Manitobans, it becomes more important than ever that we start to focus in on where those barriers are, because we don't want some people and some communities to be left out of getting those doses.
Thank you so much, Dr. Reimer. Mr. Botha, maybe just an update on our arrivals of deliveries, supply, what folks can expect to see here over the next couple of weeks from Pfizer, Moderna, AstraZeneca, and how that will impact some of the rollout here over the next couple of weeks.
Absolutely. Thanks, Jonas. So good news first, I suppose, is that we know that for Pfizer, we have a robust and steady supply. So for the week of May 3rd to the week of May 24th, we're looking at receiving approximately 74,000 doses a week of Pfizer. And then as we move into June, we're looking at 88,000 doses a week, which really shows us how from early June onwards, we're really sort of getting into second dose territory. In terms of Moderna, the shipments have been volatile in terms of when they arrive as well as their amount. So there is a shipment that should be coming either tomorrow or over the weekend. It's around 22,000 doses. It's not a lot. About 11,000 of that is allocated for our First Nation partners, which gives us about 11,000 to put through our smaller pipes. The pop-ups are the ones in our smaller pipes that can still move through that Moderna in a week. But there are other smaller pipes that we can't take all the Moderna away from to do that. And we've talked about corrections. The Congregate Living campaign continues to go on. The Moderna also is used by focused immunization teams to go to women's shelters or facilities to support domestic violence. So we can't take the Moderna away from all those small channels. And so we expect that Moderna to move a little bit slower. And in terms of the next Moderna that comes in, it is confirmed for the week of May 10th. And it's about 36,000, which is a very healthy number. That's what we'd like to see. We'd like to see more of that. And that gives us the kind of numbers that can really push a lot through our pop-ups within a week. And to round it all out, nothing new in terms of Johnson & Johnson, from the federal government. We're waiting to see what our allocation may look like. And AstraZeneca, nothing confirmed. There's a very small amount that we're getting from the federal government. They had about just over 2,000 or so that they had to distribute across the country. So we're talking at around 150 or 160 or so that we should get next week. But apart from that, there are no major shipment confirmed deliveries on AstraZeneca.
From CHVN. Taylor.
Hi, good afternoon. Looking at that vaccine dashboard, I'm sure there's a bit of a data delay, but it's looking like almost 60,000 of the AstraZeneca doses aren't in arms yet. When do these expire, and how is the province ensuring that they're not going to be wasted?
I'll just, the expiration can go to Dr. Reimer. I'm not sure where the 60,000 comes from. I'll have to double check that. My understanding is that there's 60,000 doses that have been administered, which should put us at around 20,000 that haven't yet been. So I will go and confirm that piece. I don't think that there's 60,000 unadministered. But in terms of the expiration, there is not a concern as far as we can see, but I'll pivot to Dr. Reimer on that.
Yeah, and I don't know the exact numbers either, but I will confirm that yesterday, when we talked to the folks working in the distributed channel, that they told us that they were estimating somewhere around 25,000 doses remaining. So certainly today could be more like 20 or 22,000. So certainly not 60,000 when we spoke with the folks that are running that channel. As far as expiration, the earliest expiration for the products that we have right now is May 31st. Some of them don't expire until June, but some do at the end of May. And certainly our intent would be that all 20-some thousand of them will be administered long before May 31st.
Thanks. And for folks who did get the AstraZeneca vaccine, and seeing as we're having inconsistency when it comes to shipments of this vaccine, how confident are you that they're going to be able to get a second dose in the 4 to 12 week time frame?
In terms of shipment to deliveries, I can confirm that whenever we say that we don't have anything new from the federal government, that's saying that we don't have a confirmed shipment delivery, which is what we need to plan for. There is no signal from the federal government whatsoever that we won't have a robust supply of AstraZeneca, Moderna, and Pfizer, and indeed any approved vaccine over time. So from an operations logistics perspective, it's not a supply problem so much over the medium long term as it is a planning problem when we don't know when they'll arrive. But we have lots of confidence from our federal partners that there will be enough for a second dose. But in terms of that timeline piece, I think back to you, Dr. Reimer.
Yeah, so with AstraZeneca, because of the export ban in India, that's causing a lot of challenges. So that's why we're not hearing from the federal government about when the next shipment is coming, because I think they don't know when the next shipment is coming. But they do anticipate through not just the Serum Institute of India, but through multiple factories that produce AstraZeneca. They have given us indication that they expect to have doses on hand when we need them for dose 2. For AstraZeneca, the clinical guidance is to wait at least 12 weeks in between doses, because we saw in the trials that those people who received their second dose more than 12 weeks after the first dose had a much higher efficacy than those who were at the 4-week mark, for example. So 4 weeks is really a minimum, and we recommend people wait more than 12 weeks, even if we had supply. We recommend that they wait those 12 weeks to get the best possible outcome from the vaccine. So that does buy us some time to get some more stability in the supply chain. But we also have backup plans in the off chance that there is further supply disruptions, and we want to be ready for that, because we've seen that vaccine supply chains can be unpredictable. We have talked with some of our vaccine experts and have plans to be able to provide a second dose with the same vaccine type, even if not the same manufacturer, meaning somebody who received Moderna could receive a second dose of Pfizer and vice versa, and likewise Johnson & Johnson and AstraZeneca, if we had to do that. So that's certainly not our plan and not the expectation. We're expecting we will have the doses at the time to give people the same product, but that we do have backup plans in the case that there is some sort of supply disruption. I should also note that there are studies going on right now where they're looking at what they call interchangeability, meaning they're looking at whether or not providing a second dose with a different product is worse, the same, or potentially even better as far as immune response. So if those studies come back and show us that there's a benefit to switching products, we may switch our clinical guidance so that we're recommending people get a different vaccine for dose 2. But we're really quite dependent on those trials, and we don't have any dates yet about when to expect the results. So for now, the guidance from the National Advisory Committee on Immunization is to stick with the same manufacturer as much as possible, and where that's not possible, to stick with the same vaccine type.
Our final reporter this afternoon from the Winnipeg Free Press, Danielle.
Hi there. Dr. Reimer, by what date do you anticipate you will begin offering second doses to people who are vaccinated at provincial clinics? And I guess, will the eligibility for the second dose be opened up based on the date that a person received their first dose?
Yeah, maybe I'll let Johanu take the first half of that, and then I'll answer about eligibility.
Sounds good. So as I said before, the good news is by the time we get to second doses, we will be perhaps not awash in vaccines, but pretty close to it by the time we get to early and mid-June. So the approximate timeline that we're looking at high level is once we start our second doses, which hopefully can begin as soon as early June, we're looking at around a month to get through the rest. Now, before we lock that in, we provide confirmed hard dates to Manitobans. We want to finalize our second dose plan, which, as I said before, is very close to being final. But the take-home point at the moment is that the duration of the second dose campaign, if I can put it that way, is going to be way shorter, maybe even a third as short as the duration of the first campaign, mainly due to the difference in the supply.
And as far as eligibility, I think the broad strokes plan will be to offer dose 2 in a similar order to how people got dose 1. But we have asked our medical advisory table to provide us with some advice and guidance on whether or not and where we might want to include some exceptions to that approach. So I will have to wait and see what guidance that table provides us, and then we'll be able to let Manitobans know once we have some final decisions about it. But for most people, it will probably be similar in order to when they received the first dose.
Great, thank you very much. And I noted that vaccine uptake has been higher than 85% in people over 80 years old. Do you expect that trend will continue, and how might that impact the overall timeline to reach younger cohorts if uptake is still quite high when we get to the younger ages?
Yeah, we've been really encouraged to see such great uptake in our elderly populations in Manitoba. So that's been wonderful to watch those numbers go up. And so I certainly hope that we continue to see high uptake like that. You know, a downside to high uptake is certainly that we don't have more doses, and so it would take longer to reach all Manitobans, the more of us that sign up. But I will take that downside if, 80+%, in some cases 90% of the age cohorts sign up and get a dose. That's a huge win for us, even if it means that it takes a little longer to reach all of Manitoba, because that's our goal, is to reach all adults in Manitoba. So certainly there's been, I think, a lot of drive for people who are over 70 in Manitoba to get the vaccine after what we saw about who was at high risk of ending up in the hospital and who was dying. And so we hope that the same drive appears in younger populations as we move through the age cohorts.
Thanks, everyone. This concludes our media briefing.